Our health promotion and wellness, I mentioned this is a new unit. What we did was we combined health education and health coaching. And what we're again trying to do is a lot of our members need lifestyle changes. We can do all of the care management in the world to focus on, real clinical issues, but they need assistance with health-related topics. So not just the education, but how to reach it, how to help achieve that. So these two units that I talk about, coaching and health education, they work a little bit differently, but their goal is the same. The health education unit, they provide community and on-site classes, so they'll do group classes. If you as a provider if you can assemble a group of people and you would like to have them come in there, they're more than willing to come. They do topics like smoking cessation. We recently got permission from the Veterans Affairs to conduct a weight management program called MOVE, which was very successful in the military. There is a community advisory board. This is for priority partners that they assist with. Any health fairs within the community, we encourage people to let us know because they participate in that. And these are some of the various topics that they can do classes on. Like I said, not just smoking cessation, but a lot of nutrition, obesity. We offer classes on teen health, family planning, diabetes, asthma, and prenatal classes also. Not prenatal classes, but prenatal health. Health coaching is a little bit different. Health education does group classes. Health coaching is one-on-one. And it's done for a period of up from 1 to maybe, and I'm saying 1, up to 6 or more months. And these are really lifestyle prevention. So I want to focus on stress management. I want to focus on weight management. I want to focus on smoking cessation. So they work with them individually to develop an action plan. And the action plan may, again, be helping them to determine their goals. If I know I want to lose weight and you determine that they just had a new grandson and they know, I can't do it now, but I want to be able to run. I want to be able to play. So they establish that goal and they kind of help them achieve that. And currently, we are using health coaching for USFHP and some EHP members only, but we're also looking probably to try to expand that to priority partners. And this is a lot of working with the members in that low level of the pyramid. How do we identify them for some of this? They can self-refer, but for EHP and USFHP, there's a health risk assessment that they do. And they give you a score for your personal wellness profile. Before the Suburban Network came on, we started doing this. We did a pilot in Glen Burnie. And when you do that personal wellness profile, it's really kind of a wake-up call because when I did mine, my life years were very different from my actual years. And it's kind of a real wake-up call, that spurs you on to seek some help with that. And like I said, they have direct contact with the members to develop these action plans. Now, tying the pieces back together, because I talked about social work and care management and special needs, putting all those pieces together and not just priority partners anymore. We're looking at any of these special needs populations, and I'm not going to read through all of them, but they're the challenging population, where we try to help improve their health and their services. Now, I have been tasked with these 2 HEDIS slides before I talk a little bit about outreach, because HEDIS is health effectiveness, data and information set. And these are plans that have been used basically to look at the quality of an organization. But taking it beyond that, these are scores they're value-based purchasing scores that we use. So in tandem, right now, Provider Relations is working at giving providers these reports. So a HEDIS score could be, did a diabetic member have their A1C in control? So they can help provide you the reports to see which of your members are not in compliance with that, and also alerting you to the fact that as providers, there are periodically times through the year where you may be visited by the nurses, because there are 2 ways of doing it. You can look at claims data and you can look at a chart review, and this is how we have to collect that information. So, and this is just kind of goes on to a little bit more detail. Okay, so quickly going through, I'm in the middle of the pyramid because the things are very similar. Doing an assessment, setting a goal, using the telewatch, a lot of medication adherence and reconciliation, and getting back to the members. Things are shortened here, a lot, because what we've looked at in moderate intensity is mostly the asthmatics and the diabetics. So a real focus on helping them improve their health. What we're trying to do is graduate them down to the lower level of intensity. We want to make sure that they don't go further up on the pyramid so that they need more intense follow-up. The outreach and now I'm at the very bottom, okay, when we first looked at the pyramid. This is really, you know, kind of an assessment, and what it is determine what their members' needs are. So do they have any questions about benefits or access to care? There's a real focus here on prevention, because again, if we keep them healthy at the bottom, then they don't go all the way up. So there's a lot on, you know, have they gotten their well child visits? Have they gotten their adolescent visits? Have they received their first prenatal visit or had their postpartum visit? Are they getting their immunizations? Have they had their mammogram? Have they had their pap smear? A lot of these are HEDIS measures that I've talked about, but you know, how do they work with them in terms of, and these are non-clinical folks, the outreach coordinators, but you know, their goal is to keep them healthy and keep them compliant and adherent. Referring them, if they assess them and they find out that their needs are more intense, referring them to a case management program or referring them to social work or any of the other resources that we have. The health risk assessments, you know, are collected prior. The Medicaid ones are done through the state, but like I said, the others, they could be mailed out. In terms of the process, if we ever have a member where we cannot contact them, and this is true of any of our programs, the process is we do 3 attempts, 2 phone calls, and a letter. The other thing we've done is encourage some of the providers to let us know when their members are no-show so that we can try to contact them. Because you may, you know, you tend to write them off as constant no-shows, certain, and I'm not saying certain populations, sometimes the Medicaid is a little bit worse, but not always. So then we can also try to work with you in trying to find the member. And why weren't they there? What is the barrier to care? Did they not keep your appointment because of transportation? Was it child care, which is something we really can't assist with, but we can maybe steer them to find resources. And like I said, you know, conferencing with you to help coordinate that. These are some of the initiatives that some of these I've mentioned about immunizations, well child, the emergency room, I already talked about that. We have a report that runs 3 ED visits within a 6-month period. And we can also look at the reason why they went. You know, is it for the same or related diagnosis or multiple things? You know, we're really targeting the pregnant women. And the adopted clinic or provider is where you have a high volume site, and then we can actually have somebody come in there, you know, and talk to your members that way. And any referrals in between coordinating services. Transportation, like I said, is big. Now this transportation, this particular area, may be that a member needs help getting to a provider appointment. So under the Medicaid, and this is the Priority Partners, under the Medicaid, we work with the county health departments to assist with transportation. If for some reason they cannot provide those services, and each county develops their own, well, they're given money, but they administer it in different ways. Montgomery County sometimes is stricter than others, but what we do, we want to make sure that members keep appointments. So if transportation is the issue and then the local health department cannot provide the services, then we try to work with them to make sure they get to your office. And this is contact information. We've got all the numbers up there, case management, health promotion, wellness, outreach, etc. So you're free to call those at any particular point.